Welcome to Health Coaching and Beyond. As many of you know, we alternate conversations between Tim and I, chewing over hot topics, latest news and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. This week, it's a bit of a different combination of peak directors. I'm joined by our education director, Caroline. We capitalise on her expertise as a researcher to discuss a couple of papers that caught our eye this week. We use these to not only highlight new peer-reviewed evidence to support health coaching, but also to think about how to critically examine published evidence and reflect how it can apply to your practice, or maybe not. This leads us into talking about how we can all generate useful evidence about the value of health coaching in research or in everyday practice. As always, we hope to get you thinking. So hello folks, back to another podcast, and I am delighted today that I'm joined by Caroline, another one of our directors. We're going to have a little deep dive into a few research papers that have caught our eye, and no one better to help me with that than Caroline. Hi Caroline.
Hi, great to be back in the hot seat with you, Ollie.
Yes, and I mean, let's remind listeners your background is as a researcher and from an education background, so you've got a good degree of expertise about judging evidence and how you can apply it to different situations.
Yeah, so always love a little delve into the literature and looking at some of the, basically what's being written at the moment in this field around health and wellbeing coaching. It's changing all the time, and there's also a global literature that's now emerging. So it's just a nice opportunity just to dip a toe in, have a look at a couple of recent papers, and really just kind of use that to stimulate some thinking around this hot topic.
Brilliant. And you've written a fair few papers in your time as well, haven't you, and a few books. So I would say you're pretty well qualified to evaluate evidence. It's certainly something you've been familiar with in your journey through Cambridge and through your research background.
Yeah, well, I do my bit. Not written very much for a while, but yeah, still trying to keep abreast of what's going on. But also just some of the challenges of research, because as you probably know, the more sort of robust studies often come with a price tag. It's hard to get funding. It's hard to carve out time. In this field, it's sometimes hard to access the populations that we want to talk to, whether that's the hardworking practitioners or whether that's the clients. Clients don't necessarily always want to be kind of talking about the work that they're doing with the health coaches that they're seeing. So it is a challenging space, I would say, to be in. But one that prompts us to think creatively, really, about, what can we do? There's a few barriers, there's a few hurdles, but what can we do together to build this picture of what health and wellbeing coaching can look like, going forward into the future?
Yeah, brilliant. And we know a lot of people, don't we, are actually conducting research. And like you say, it's difficult to do, often on top of the day job, but it really adds value. And I'm involved with some research from a community team working with Birmingham University, and they're looking at how health coaching applies in community settings and perhaps to reduce health inequality. So research is a great opportunity to deepen our understanding, isn't it? And I'm really sorry we're keeping you away from research now with your role as a director in peak health coaching. We're keeping you too busy as our education director, aren't we?
Well, it's all about finding the right balance, isn't it? So this is a nice opportunity today, just to kind of, pique my interest. So let's see where we go. Do you want to kick off then?
Well, let's dive in. Yeah, so there's two papers that kind of caught our eye, both published this month, quite different, which would be interesting. And we'll put the links in the show notes. So the first one was in JAMA Network, so the Journal of the American Medical Association. And this one caught our eye because it was quite clinical. They did a study looking at how you can engage women in ongoing blood pressure management and control who have been identified with raised blood pressure during pregnancy. And that's the background to that, is that it can be quite tricky. People often have raised blood pressure diagnosed in pregnancy. It's a real risk for ongoing problems later in life. And actually, it's a great opportunity to monitor people and to maintain good control. So this study, and I'll just summarize it, and you can add your thoughts as well, Caroline. So it was a reasonable size study, 140 people. They aimed to put 70 people in each arm of the study. So they had a control group, which is always an advantage. In the end, they got around 45 people in each arm who fully completed the study. And the idea was that when blood pressure had been identified in pregnancy, they then either teamed them up with usual care or with health coach support as an addition to support them in self-monitoring their blood pressure and then maintaining good follow-up and contact. And the headlines for me were that having health coaching support alongside usual medical care had much better engagement. There was a 70% of those women in the health coaching support team stayed engaged versus only 40 in the non-health coaching. And ultimately, they ended up with better blood pressure control a year down the line. So that was how I read it, that health coaching added an additional boost in this study. What stood out for you, Caroline?
Well, it's so interesting, isn't it? Kind of, and the different sort of takes. So,
am I over positive here?
So at a glance, what I noticed was that this study was conducted in the United States. It happened in one single hospital. And the research was conducted over a couple of years from 2023 to 2025. So that straight away tells you quite a lot of effort from one kind of team in one locale, as it were. And they were looking at does health coaching with self-measured blood pressure monitoring in the first year after delivery improve healthcare engagement and blood pressure control. So those are two different things. And then thirdly, they were looking at whether it changed health behaviours. That was a kind of a third bit. And as you say, what they found was those that had the health coaching intervention were more likely to turn up to a primary care appointment a year postpartum compared to the control arm. And as you say, the blood pressure was better controlled in the group that had the health coaching intervention. But of course, I sort of dug a little bit further because I wanted to know, well, when you say health coaching, well, what do you really mean? And found that this was these were sort of nursing professionals who had had some sort of motivational interviewing and what I think was described as coach training, kind of pre-trial kind of input, as it were. So they weren't kind of health coaches that had trained in the sense that if you'd done a PCI accredited course in England, the 4-day course to work as a health and wellbeing coach in the NHS, it wasn't quite like that. They already had a different kind of professional hat on. So it was kind of, as soon as you start to look at this is just one example of a study. These are some of the things that you kind of have to look at. And I suppose what really struck me was when we're kind of thinking about doing research or when we're reading research in this area, it's crucial to write up and know exactly what the intervention is so that we can see, if there's efficacy, where is it coming from? Is it because they were nurses or is it because they were using a health coaching approach? And also, I think this was done by telephone. I think the first 6 months that there were calls every 2 weeks to the participants, and then after that, I think it was monthly. So again, the kind of the delivery of that health coaching intervention was quite specific in this trial, and yielded that outcome that we're sort of talking about there. So just great. Kind of a few headlines from me.
I love that. And already that illustrates, doesn't it, the difference between a seasoned researcher and a GP. Us GPs will just just bash on through to the end result. And actually what I really appreciate there is that the context really matters, doesn't it? And I guess when we're looking at studies, you've landed right in on some of the key issues. How generalizable is this to the setting that we're working in? So, you say it was an American setting. People had perhaps different training to the training they have in the UK. It was telephone rather than face-to-face. And we're not exactly sure what training they had or what skill set these nurses had, which is, I guess, always a bit of a trouble with health coaching as a whole, isn't it? It's quite heterogeneous, isn't it? It's always hard to know exactly what's being studied in a lot of these health coaching studies.
Yeah, I mean, to be fair, I think this is one of the great contributions of the Personalised Care Institute in England, because they did set out a curriculum for health coaching, and they did sort of specify, kind of the 4-day program. And there are many different accredited training providers out there now, and I'm sure that they're all doing a slightly different version of that course. But actually, it has brought some consistency. So, in England, actually, I think we have got a fighting chance, partly because we have a national health service, and the PCI falls under the RCGP, etc. Actually, we've got a real chance of gathering, kind of better data, if you like, looking at that kind of consistency of training that people have had. Whereas obviously, in the US, there's a lot more private healthcare provision, and, there isn't that same sort of breadth of consistency in basic training that people might have had. And I guess that speaks to the bigger picture of the emerging profession of health and wellbeing coaching globally, that there is not yet one single kind of training pathway, if you like. But in a country like, in the UK, where we have that kind of more consistent approach across a national health service, perhaps we have got a better chance in some ways than somewhere like the US.
Yeah, absolutely. And I know that the NHS has just reissued their standards for health coaching, which I don't think we'll get into today, but we may well have a future podcast around that, because standards and accreditation, it is a little bit of a minefield still, isn't it? But it's becoming clearer with some really good positive actors in this space for sure. So interesting. With all those caveats in mind, I think it's really important, isn't it, to look at these things critically. I guess what I take it positively, that health coaching in this situation did have quite a significant impact on people's ability to engage and stay engaged, which I think is something that we often say about health coaching, isn't it? It meets people where they're at. You perhaps lower the barrier to people joining in and, sort of feeling like it's, the services apply to them and they feel welcome. They feel like it's something they can engage with. And maybe because of that, or maybe because of further support, teaching people to self-manage their own blood pressure in this study, is again a great way of improving outcomes, because in the end the blood pressures were significantly better. It was at the less than 1% level, so really significant changes in blood pressure at the end of this 12 months.
Yeah, definitely. And yeah, clearly there was that kind of significant kind of improvement, if you like, in terms of the blood pressure. But I think the other figure that's really interesting is the level of engagement. So they were, in their sort of lit review at the start of the paper, they were kind of saying, there's the evidence that enabling these women to turn up to a primary care appointment a year postpartum boded well. It was a really good sort of sign in terms of supporting the kind of management of hypertension and kind of related conditions. And what they found in the intervention group, so the group that had the health coaching intervention, 71% of them turned up to that 1-year primary care appointment, compared to just 42% of those that were in the control arm. And so that is a really significant difference. And it just makes you wonder, doesn't it, that maybe that sort of partnership approach, the kind of, feeling there's somebody alongside you, someone checking in and giving you that chance to talk along the way, help to kind of build rapport, sustain engagement, and ultimately get them to turn up to that 1-year on appointment. And I think that does seem like a useful impact there.
Completely. And I think, I'm reminded by patients how scary, GP practices and hospitals and any health setting is. And, it's actually a really big thing often just to walk through the door, isn't it? And to engage. And as you say, maybe that human to human relationship that you build with a health coach who's curious about what's going on and interested in you, really breaks that barrier down. And I think certainly as a GP, I really underestimate that. I think, well, why wouldn't everybody turn up to their appointment? Why wouldn't everybody interested in controlling their blood pressure? But it's actually often a lot more psychologically difficult than we give credit.
Yeah, absolutely. I think it's building that trust, and then also that, valuing oneself and having somebody else, give you that time of day and, it might just raise the bar on where that is on someone's list of priorities, particularly, having had a new baby. I mean, let's face it, that comes with its own challenges. So to be able
You've got your hands full.
to be able to, prioritize your own health and to kind of see that value in turning up to an appointment and acknowledging the support that might be out there that could be useful. That kind of role of the health coach, you can definitely kind of see how that could add to that benefit.
Yeah, absolutely. So good to see in a well-respected. Oh, your mic a bit there. In a well-respected, peer-reviewed journal, that actually there is evidence of the sort of stuff that we think is likely to happen. Relationships improve engagement. Improved engagement, it improves outcome. So great to see that in black and white in a respected journal. Shall we switch over to the next one? Just thinking about.
Yes.
So our next journal was the Gerontologist, again another peer-reviewed, well-respected journal. And this was a bit different, wasn't it? Do you want to describe this one? I think I did a poor effort of describing the last one. God, why don't you lead off on this one?
I think you did very well. So this one was about evaluating a coaching intervention for dementia care practice recommendations in care communities. And again, it was a randomized controlled trial. And again, it was conducted in America. So randomized controlled trials, for people who don't know, RCTs, that get abbreviated to, is where participants are randomly assigned to different groups, where you have a control group where a usual pattern of behavior continues, and then a kind of an intervention group where you're kind of doing something different. Both the studies we're looking at today are these RCTs. And I have to say, if you're applying for funding, particularly in the UK and Europe, I've seen it, and the US, if you put RCT in there, it does seem that you get higher up the pile. The funders do like randomized controlled trials. I personally do think there are other ways to do evaluation, and we might get onto that later.
Well, they've always been sort of considered the gold standard, haven't they? And I know one of the criticisms gets leveled at things like health coaching is that you get the results get distorted by regression to the mean, meaning that over time, if you pick someone who's got high acuity, lots of problems going on, and you do anything for them, people will have naturally settled down with time, and that gets caught in there. So having the control group controls for that. So you really are, following two groups over time, and it mitigates for that sort of natural settling over time that might happen with people, what they call regression to the mean, right?
Exactly. Yeah. So anyway,
I got that right. As a non-researcher, I got that right.
This study, again, a new one that's just recently come out, where they start off talking about the over 7 million adults aged 65 and older living with Alzheimer's disease in the United States, and the number projected to increase. And I think we have seen that being reflected in other national statistics as well. And then also saying that today, 42% of residents in residential care communities and 58% of long-stay nursing home residents are living with Alzheimer's disease or related dementias, according to these US statistics. So they're kind of highlighting this as quite a significant area. But interestingly, in this study, they weren't actually looking at coaching for the residents or the patients, if you like. They were actually looking at coaching for the caregivers in these different settings. Yeah. And this was based on, looking at the wider research that's showing that person-centeredness within care communities can support a broader cultural change movement. And, in terms of thinking about dignity, respect, supporting empowerment and self-determination for residents. And so that was the kind of the motivation behind this. So the study was looking at the effect of what was called the Care Community Coaching Program on employee satisfaction and staff confidence in providing dementia care, and then the delivery of person-centered practices in care communities. And in this particular case was in the state of Ohio in the United States. And they, again, found that using this intervention of coaching to support these health and social care workers, that it did seem to make a significant difference to their well-being and their sense of satisfaction at work.
Yeah, and I mean, I may be taking too much out of this. You can check me back. But what I really liked about this study was I suppose it sort of mimics what's going on in the NHS to some degree, where we're training staff to have health coaching skills so they can apply them with the people they're working with. So, whether you're a GP or a nurse, a direct health coach, a social prescriber. And one of our sort of things we've always held on to, isn't it, is that we improve your work satisfaction. It's not another thing just layered on top of what you have to do. It's giving you skills that may help you to enjoy work and help you to perform better. Do you think that's too much of an extension to sort of like draw parallels with that? I know this is care home staff in America, but what do you think about that?
Well, I think it was an interesting premise, I think, because it was kind of coaching people to kind of use a coaching approach. There was this kind of almost like a two-step process going on where the caregivers were being coached to kind of understand this more person-centered way of working, which they were then implementing. And then again, you have this sort of double effect going on in terms of how that then made the workers feel, as well as the impact on the residents that were living with dementia or a related dementia condition. So I think one of the things that this surfaces is when we're looking at evaluation, the first question you have to ask is evaluation of what? What is it that we are evaluating? And I think oftentimes we focus on one piece of the jigsaw, but we actually might miss other pieces and have blind spots. And in fact, I think sometimes some of the efficacy of the interventions may have a bigger impact in the blind spot, in the bits that we're not looking at. So actually how workers are feeling, and how their job satisfaction, the meaning that their work has, you could say that actually in some situations that's as important or even more important than actually seeing a tangible kind of biometric, measurable shift in what's happening for the clients.
Yeah.
So I thought it held up quite a nice mirror to that.
Yeah, it's really interesting, isn't it? And I have to say, really encouragingly, I've been involved in a few projects recently, some in Sheffield and some further afield, where they are starting to look at that sort of logic model of expected stages of change. So, often you sort of go, well, does health coaching, improve health outcomes? Does it stop people going to A&E? Does it, stop heart attacks and strokes? And I guess often the answer is yes, it probably does, but quite way down the line. But what you might see first is a shift in mindset of how the system operates and how policies are put into place. Then you might see that staff feel better about their work and are able to implement new skills. And then you might see perhaps some early markers of change, which might be around people engaging, like in the last study, turning up, and then down the line, you might start to see health outcomes like improved blood pressure or, in this case, people having better person-centered care in the care home. And then maybe that leads on to things that really matter for the whole system as a whole. Maybe reduce falls in care home residents, or people turning up to less A&E appointments, or having less unscheduled care. So there's a bit of a sort of logic model and a pattern that, to me, this study just, like you say, it's shining a light on a little bit of that sort of almost expected progression that we might see.
Yeah, absolutely. And I think, if we were sort of moving on a little bit to kind of think about evaluating the impact of health coaching in a bigger context. I mean, we're just using these studies as a kind of a sort of a segue into that, in a sense. I think it's helpful. I mean, the dementia study that we're just looking at, for example, some of the variables that they were looking at is they were looking at where were these care communities located. And they were saying, for example, that in the intervention group, more of them were located in urban areas, whereas the control group, more of them were in, kind of rural areas. They also looked at things like the average age of the caregivers. And they also looked at the numbers of years of experience of the caregivers. And so you start to see, the people who've set up this research have, picked certain variables to kind of look at, and, kind of urban, rural, kind of age, length of experience, things like that. Whereas in another cultural context, actually, you might look at quite different things. So you might look at the type of training that somebody's had. You might be looking at different kind of ages or different demographics of the clients that are kind of having the health coaching intervention. So that whether that might be kind of a youth kind of demographic, for example, or it might be in terms of socioeconomic demographics. So what are the kind of social variables that that are impacting the clients? So there's quite a lot to think about in designing a good evaluation study. I think what we're picking up, if we were kind of picking out from these two studies that we've looked at, where you shine the spotlight is one of those things. So are we looking at the clients? Are we looking at the caregivers? Are we looking at something else, the institutional culture? And when we're looking at those specific variables, what's important, and having some kind of a justification, some sort of a rationale for why we might look at age or length of experience.
Yeah. And again, a great example of you looking deeper in the surface than me. I didn't notice the differences there. There might not have been. Was there a difference between the sort of experience of the caregivers and the age?
Well, they were saying that across those two groups, that on average, participants had just over 14 years of experience working in community-based care in the control group, and 15 in the intervention group. So it was actually sort
quite
of
well matched,
fairly similar. And there wasn't a significant difference between the two groups. But what I took from that was, wow, these guys are experienced. They've stuck at it for 14 to 15 years, maybe not in the same setting, but in the same, type of work. And actually what that said to me is, do you know what? If you get your training right, and if you get your support right for these workers, they are doing, they're staying. There's longevity. They're staying in the job. And actually, I was really curious to know, because I don't imagine this work is easy. I was really curious to know what was it that had enabled people, if you like, to be resilient in those settings.
Yeah. I see what you mean. So in some ways, it's good to know between control group that you're looking at similar groups, but also maybe there might be future times when you go, wouldn't it be interesting to study what a difference these things make? And like you say, it just does point out that people are often staying in these caring roles for a long time. So a little bit of investment in training can compound, because they're going to stay there for 15 years, and you're going to get that ongoing benefit if you've improve their satisfaction at work and improve their the capability of what they can deliver. Yeah, really interesting stuff. So, I mean, I think you've pulled out a few really important points, Sarah, when we're looking at those studies. Is you do need to know the details of what's gone on, what setting it's in, what sort of interventions happen, and delving underneath the surface of that, seeing if there's a control group, because that makes it a bit more robust, but specifically then thinking, is have they done things in a setting with the sort of people that I work with, so that it could be generalizable to the sort of situation I'm dealing with, like a GP practice in the NHS, perhaps, or a stroke service in a hospital, or maybe even a workplace. I mean, that's interesting, isn't it? Whether you take a parallel. What happens when you train people in workplaces to be good health coaches with their colleagues, and you have to sort of decide, don't you, whether you could extrapolate the evidence from one setting to another.
Yeah, and I suppose that kind of brings us to the what is the data that we think is worth gathering. And, of course, we've got the kind of broad categories. I mean, I'm just, for those of you that might not be, wild about doing research, you've got the kind of quantitative data, so the more numerical, statistical kind of data. And then you've got your qualitative, which is, kind of more perhaps attitude, perception, slightly more nebulous kind of narrative type
stories.
data.
Yeah, they often say stories, don't they?
Yeah. And then you've got your kind of biometric data where you're doing something like taking a blood pressure measurement or, doing a blood test or something like that. But then there's other kinds of data that's about, how somebody feels about something. How confident does someone feel, for example, which is not something that there's a kind of a precise scientific measure for. It's more perception based. And I think that there is a tendency still, I think, to kind of err towards what people describe as the hard sciences and to go more for that biometric data and go more, towards the sort of stats, quantitative side of things. And personally, I would kind of caution around that. I think that data is useful, and I think sometimes to speak to stakeholders and funders, we kind of need to have that. We need to have the numbers. We need to know how much it costs. We need to know how much the blood pressure dropped, or whatever that biometric bit of data might be. How many hours were saved in the clinic or whatever it was. But actually, some of the what people talk about sometimes as softer data, that kind of the qualitative data, I think can be quality, actually high quality, and really kind of invaluable. And for example, in the training courses that we do, our higher level courses, our learners have to undertake case studies and they have to look at the impact of their work. But we do give them quite a lot of latitude in how they do that. And they do have a choice of what kind of data they will draw on. And actually, frequently, they draw on the kind of patient-reported outcome measures. And they do look at perceptions. They do look at client experience. They do reflect on their own experience as a practitioner. And they all engage in deep, very thoughtful, reflective practice. And that's not something that you can put a statistic to easily necessarily, and it's not a biometric measure, but actually it can give us a really, really kind of rich, deep understanding of what is actually happening in those health coaching relationships. You can't necessarily distill to just a number. People like Brené Brown talk about the power of storytelling, and actually the stories that clients tell, the stories that health coaches tell about the power of their work and the impact that it's had, I think is super valuable. So I think if you're out there kind of thinking, I want to maybe think a bit more about the impact of my work, I would encourage you to kind of look at both. To think about, what is the kind of, if you like, the hard scientific quantitative data that I can capture, but also what is some of that more the qualitative, the narrative, the storytelling type data that will help bring to life what is happening in those coaching interactions.
Yeah, and I mean, that's so important, isn't it? It's the two sides of a coin, isn't it? I've often heard people say that the qualitative stuff, the numbers, sorry, the quantitative stuff, the numbers is more like that. It wins the head, wins the finance argument. Wins the strategy argument, and let me get it right around. The qualitative stuff, the storytelling, wins the heart. And it can need a bit of each, can't it? I mean, it's really interesting, isn't it? I know you're a big follower of our new Prime Minister's Instagram account, and he's a master at telling the story of the heart, isn't he? He tells, he gets underneath the story of what's going on, and perhaps more than just throwing out statistics, because that often wins the argument. So yeah, it's fascinating, isn't it? How we evidence impact and what we're using it for, and the job the job it needs to do for us, I guess.
Yeah, I mean, I guess the other thing that I would say is that if people are out there thinking about going and doing some data gathering and whatnot, is about consistency. So aiming for some kind of consistency across, different cases or different populations that you might be looking at. And then also thinking about what data can you collect right at the beginning of a process. So even before you've begun a health coaching intervention. So that kind of that first contact, that kind of when you're having those kind of chemistry conversations, or on that kind of initial meet and greet, or even before, what data, what baseline data can you capture of whichever type you kind of choose? And then at the end of your intervention, can you relook at that data? So can you capture it at the next time point? So whatever you looked at the beginning, can you look at it again at the end? And if possible, somewhere in the meantime. That's not, the kind of midpoint data is not always possible. But it's aiming for that consistency, because then you've got a kind of a beginning and end that you can compare. And I guess that's one of the things that I would say. I mean, I've seen, I don't know, hundreds, if not thousands of case studies. And sometimes it's a bit sad, really, because you sort of think, oh my gosh, what an amazing story. And then you get to the end and you're kind of waiting for them to tell you what happened compared to the beginning, and it's not in there. Or conversely, sometimes not very much is said about what happened at the beginning of the process, but then at the end, you've got some really kind of hard data, and you're like going, well, that's great, but like, how do I know what that means? Because I don't know what the beginning of the story was. So, that's I suppose, my sort of, in a nutshell, if you're going out there looking at the impact of what you're doing, look at the beginning, the end, the middle if you can, and weigh up the different kinds of data that you might look at, and don't just be led by the kind of the hard science, as it were.
Yeah, and that really sings to. We've been talking a lot with Jag Munda and people like that, haven't we? And his line is really that capture simple stuff, because I think the challenge often for health coaches, isn't it, is they don't want to lead in with a kind of big long questionnaire. It's hard to get initial data. Whereas if your initial data is really useful or feels useful and relevant to the health coach and to the patient, it's perhaps easier to get it in early and maybe reproduce it as you go along. So keep it really simple, keep it useful for the interaction. Help use stuff that helps you build relationship. It's why I love that, that single question activation. Tell me a little bit about what you're doing to look after yourself. You can use it as a sort of outcome marker of what's happening at the start, maybe the middle and the end, but it also adds value to your conversation. So I think that's a bit of the trick, is how do you find really simple measures that are powerful but add value such that you will use them? Because I guess the best marker is the one you're going to, like you say, you can consistently do at the start, the middle and the end.
Yeah, absolutely. And, I do think that, co-production is a, good way to go, whether that's involving interdisciplinary colleagues. So, we're biased, right? Because we've bought into health coaching. We think health coaching is great. And if you're out there and you've trained in health coaching, whether that's your kind of sole role or whether you're kind of wearing different hats or bringing it into your physio practice, your pharmacy practice or whatever, we are biased. We think it's a great idea. So actually bringing in other colleagues, so colleagues who are not necessarily well versed in health coaching approaches, the theories, the concepts, the models that we're using, actually can help to make your studies more robust. So hearing from a medical clinician who is really not interested in health coaching can be, perhaps challenging, but actually quite useful.
Seek out the naysayers. Is that what you mean?
A little bit, yeah. And I think similarly with the client groups, actually understanding from them what's important to them and understanding for them what success looks like, because actually the things that they are identifying as success might not be the things that you would necessarily look at, and they might not be the things that whoever your funders are would necessarily look at. And the latter partly because they might be approaching it with a different mindset. And so, that kind of idea of kind of co-design, co-production and participation, and involving people in, well, how will we know if this has been useful? How will we know if there's been a value to this? How will we know if it will be a good idea to keep going with it? Actually bringing those conversations, I think, is really important.
I think that's maybe a fabulous place to finish off on. So basically, if you're going to take the time to gather data, you're going to do research, make sure you understand what's important to all the stakeholders, your funders, your patients, your colleagues, bring them into the planning and make sure the stuff you're capturing is of value to everybody. Brilliant. Well, Caroline, we've filled, time has just flown by. Is there anything else that you want to say before we finish about?
Yeah, I told you, once you get me going, once you just wind me up.
No, it's great. I love it. It just bring home to me the difference in a researcher's mind and a GP's mind. We're all enthusiastic, but we're maybe not so good with the detail, and it's often a mixture of both, isn't it? Any final points?
You know, obviously there is a big health and wellbeing coaching community out there. Certainly, obviously people that we've trained, but many, many others as well. If you think you've come up with a great idea about how to evaluate the impacts of the work that you're doing, don't keep it to yourself. You know, share it, because I think there's a lot that we can learn from each other. And certainly at Peak, we're always delighted to kind of hear from people who are sort of dabbling in the world of research and evaluation. So yeah, the invitation's there. Reach out if you'd like to chat further.
Sharing and collaboration. Lovely. Caroline, a real pleasure chatting to you. Thank you. And we will come back to those standards later, which may seem a bit dry on the surface, but actually is really, really crucial, isn't it, for evaluation, but also just for moving forward as a profession. So something for the future. Thanks so much.
See you again soon. Cheers.